Hello and welcome to my presentation on the science and research of the Panadent Articulator System. My name is Thomas Lee. I'm the son of Dr. Robert Lee, who did studies on jaw movements engraved in solid plastic for articulator controls, which led to the development of the Panadent Articulator. He also coined the word bioaesthetics and defined it as the study or theory of the beauty of living things in their natural forms and functions. So there's not only beauty in a mountain lion in its form, but there's also a beauty in the way it functions. Well, in mechanical engineering, form follows function. In other words, if you have a preconceived function in mind that you want to fly high, undetected, and be able to drop bombs, you develop a form to accomplish that function that would look something like this. Now, in biology, it's a complete opposite. Function follows form. That's because form is a given factor. It's genetic. Matter of fact, if we deviate this form ever so slightly by just cutting a couple feathers here, we'll deviate the function of this bird and he'll no longer be able to fly. Well, he gave it a better definition for dentistry as orofacial dental gnathic bioaesthetics and defined that as the study or theory of the beauty of the mouth, the face, the teeth, the jaws, and the neuromuscular system as they interrelate to each other in normal genetic forms and functions. The bioaesthetic forms would be the form of the individual teeth, the form of the occluded dentition, the form of the joints, the periodontal forms, as well as the form of the smile and the form of the face. What he did is studied healthy dentitions that had little or no wear, no periodontal disease, and no TMD problems and found similarities, or what he called observations of long-lasting, trouble-free natural dentitions. And that showed that MIP or CO equaled CR within a half a millimeter, that all these patients had a stable condylar position. There's also a papillary maxillary teeth overlap, that the incisor overlap averaged vertically 3 to 5 millimeters and horizontally 2 to 3 millimeters. The canine overlap averaged vertically 4 to 5 millimeters, with the horizontal being half a millimeter to 1 millimeter. There's also genetic-like sharp crown forms and a bioaesthetic smile. What he observed was that the centrals are relatively large and long, the laterals are short and rounded, and the canines are long and pointed, and so are all the rest of the posterior teeth, which creates a more efficient cutting surface, compared to someone's preconceived notion of what teeth should look like. And if they deviated the forms of these teeth, we also believe they deviated the function, compared to a natural set of dentition that God or Mother Nature or whoever you believed in designed. So he developed his bioaesthetic study models, which is a biological model of health, which leads to a very bioaesthetic smile. Well, he often said regarding dental gnathic functions, form is everything. You can get more information on bioaesthetic dentistry by contacting Panadent or Bioaesthetics. So what is an articulator? Well, the average person might ask if that's someone that speaks well. Dentists like to call them mandibular movement simulators, but I like to simply call them that they're a chewing simulator. What we're trying to do is duplicate the way someone chews, which is a very dynamic three-dimensional movement that includes an opening, lateral, and closing movement. So as we look at the introduction to human chewing by Dr. Gibbs and Lundeen, we can see the differences in these different movements. So let's look at the video at this time.
The computer plots reveal some interesting differences between the right and left condylar movement patterns. Upon opening, the working side translates along a course that is often superior to its closing movement. Distraction, or separation of the working side condyle from its temporal articulating component, is a common occurrence. The separation begins during the closing stroke, before the teeth have contacted the resistance created by food between them. From point 7, the working condyle moves upward and forward through point 8 to its intercuspal position at point 1, guided by tooth contact. The non-working side shows little evidence of separation between its opening and closing tracings. Some authors feel that the non-working side is under a heavier load, and the thinner center part of the disc is interposed between the condyle and articular eminence throughout the opening and closing movement. Again, action of the non-working side condyle is shown in the split-screen simultaneous views. The subject is now chewing on the right side. The black dot is located on the non-working condyle.
Well, there's been many articulators developed to try to simulate these jaw movements, and some have kind of joked around by using a barn door hinge, or even using what they call a wristilator, or what I call the living articulator. But there's been many patents issued on different articulator design trying to duplicate these jaw movements or based on different philosophies of occlusion. What is occlusion or function? It's the state of being closed or the act of closure. Now, most dentists agree that they should have equal simultaneous bilateral contacts of the teeth, but they may or may not look at what's going on here at the joint. The act of closure is a much more dynamic movement where you have afferent stimuli from the periodontal membrane, mucosas, lips, tongue, cheeks, muscles, and TMJ that send signals to the central nervous system that then sends efferent stimuli to the muscles of mastication. It deals with condylar guidance, and as we look at Dr. Tanaka's work on dissected sections of the temporomandibular joint, we can see the anatomy of the condyle, the biconcave shape of the disc, the fossa, and the eminence. And notice how all these surfaces are curvilinear in nature. Well, articulators, are they anatomical or are they mathematical? When I superimpose a mandible onto a lower frame of an articulator, I'm trying to imagine how the steel ball bearing is supposed to anatomically represent this condyle that looks like a football. Well, if you take a sphere and reduce it infinitely small, it becomes a point. You go any distance from that point, you take another sphere, reduce it infinitely small, it becomes a second point. 2 points in space define a straight line. And that's what we're doing with these two steel ball bearings, is simulating a straight line or the hinge axis of the mandible. So articulators simulate hinge axis movements, not condyle movements per se. And as you move your jaw laterally, some authors say you will rotate around a vertical axis as well as a sagittal axis. But to record condylar movements, we need only to track 2 points a fixed distance apart on the hinge axis, since any movement of the mandible around a vertical or sagittal axis will always move the hinge axis. It's also the one axis that's constant with both condyles. Well, how far apart do the condyles need to be? Well, they say there's an effective intercondylar distance. And here's an author that's showing a small, medium, and large intercondylar distance and showing that there's a change in the groove directions of your teeth. And here's another author that's also going to show it, and he's going to show the lines even further here so you can really show the separation in the lines between a small, medium, and large intercondylar distance. But this picture is out of perspective. You can't really expect me to believe that this large intercondylar distance is going to come down here, turn at the ramus, come to the arch form, around the arch form, and then bend back out to condyle number 3. It's just out of perspective. It seems that if you have a larger intercondylar distance, you might also have a wider arch. But here's another author that's going to even prove the point even more. And we may or may not be able to move our jaws that far laterally, but he's showing the lines that far to prove the point. Well, my father never did believe research, so he looked at the functional range. And when you move your jaw laterally to canine, it's approximately 3 millimeters. It's also approximately 3 millimeters from the central fossa to the cusp tip of your molar. So he took a set of models and ground down the teeth to make a writing surface and mounted into an articulator that had a small, medium, and large intercondylar distance. Then he took the compass and started the center of the tooth at the small intercondylar distance and drew the first line. He then indexed the compass at the medium intercondylar distance, readjusting the compass to the same starting point, drawing the second line. Then he put it at the wide intercondylar distance, readjusting the compass again to the same starting point to draw the third line. We can now see the 3 lines, and as we look on the working side, as we move towards the back of the mouth, we can see a separation in the lines. But again, he ground down these teeth, which made them much wider. So if we draw back in where the top of the tooth is, I can't see how you can wax the difference between small, medium, and large within the functional range of the top of the tooth. Just to show we didn't go less than the 3 millimeter functional range, here we're showing 3.5 millimeters. Well, it all starts with the hinge axis that McCollum and their group discovered in 1926, and there's been many people coming up with different terms that basically describe the same thing, that there's an axis of rotation within the joint, or the condyle, when the mandible opens or closes. Well, the value of the hinge axis in articulators is it makes axis movements valid at various vertical dimensions. You can also change occlusal vertical dimension of occlusion on the articulator and maintain the cast and centric relation. It's also a repeatable reference location. We can locate this axis by using an AxiPath recorder, where we put a clutch over the lower teeth so we can add this crossbar and put on some recording arms that we can move over a graph paper on a head frame that's over the joint level. We can then move the stylus in different locations on the graph paper, have the patient open and close, and see the arcs that the stylus makes on the graph paper, moving the stylus until that stylus just rotates at a center point, locating the hinge axis of the patient. We can then mark the skin where that hinge axis point is. So then we come back with a face bow. We can add a crossbar and clamp here so we can add back the recording arms to come back to that spot we marked on the skin so that we can transfer that true hinge axis of the patient over to the true hinge axis of the articulator so when we mount the cast to the true hinge axis. We can also use an arbitrary relationship to the axis by using a face bow, which uses an arbitrary relationship using the ears. So when we mount the cast in the articulator, we have an arbitrary relation to the axis of rotation. But most dentistry is done on these small disposable articulators where the axis of rotation is down here behind the third molar. It's actually in line with the occlusal plane here at point C, which creates a pure vertical movement out of the fossa. In other words, it's impossible to have interferences on these small disposable articulators where the axis of rotation is at point C in line with the occlusal plane. The problem arises when you place those restorations in the mouth, the axis of rotation moves up by point A, which creates this downward and backward rotation. And this axis of rotation discrepancy will lead to you adjusting the mesial inclines of the upper teeth and the distal inclines of the lower teeth every single time. So we know we need an articulator that more anatomically represents the axis of the patient. So when we mount the cast in the articulator, we'll be duplicating the movements more accurately. Now I realize that my mounting plates are constant to the axis, irregardless of where the models are mounted using a near bow or a true hinge axis. So we developed a secondary receiving port in the back of the mounting plate to plug in this PAL articulator. This PAL articulator has the same axis of rotation as the full-size articulator. It has a built-in support stand for patient consultations. It can be opened past 90 degrees to separate the frames. It also has vertical and horizontal aesthetic alignment guides built into the frame. You can then push a button in the plate to release the model so you can go back to the full-size Panadent to do any quality control or final adjustments using the curvilinear analogs of motion as your guide. The plane of occlusion. Well, we have steep planes of occlusion, flat planes of occlusion, and reverse planes of occlusion situations. And steep planes of occlusions are hard to work out functionally, and reverse planes look bad aesthetically. So we want to get the relationship of the plane of occlusion to a plane of reference. And we do this by using a face bow. We first take a bite fork registration of the patient's maxillary teeth, which is picking up the plane of occlusion. Then we add the face bow, where the upper surface of this face bow is related to the plane of reference. Again, we're referencing to an arbitrary relationship of the axis using the ears. Then we're referencing 22 millimeters below nasion, where the average canthus of the eye is, setting up the axis orbital plane of reference. Connecting the clamp to the bite fork connects the two planes together. So when we go to the articulator, we'll get the plane of occlusion as it relates to a plane of reference on the articulator. Now this may or may not be aesthetically correct, but it will be functionally correct. So we do have to look at the functional plane versus the aesthetic plane. Most dentists are taught to make the teeth parallel to the eyes, but if the eyes are uneven, then there'll be a cant to the occlusal plane as well. My father advocated making the teeth parallel to the horizon when the patient's mid-sagittal is erect, irregardless of soft tissue landmarks. In other words, teeth are part of the hard tissue system and should be rated perpendicular to the vertebral column. Well, face bows and true hinge axis bows are not related to the eyes or the horizon. They're related either to the true hinge axis or the ears, which may be also uneven. And of course, even though these teeth may be functionally correct, they look aesthetically bad when they go to the mouth based on a lack of aesthetic information. At an anthropological society meeting in Frankfurt, Germany, they said from the top of the ear hole porion to the lower border of the eye orbitale was basically horizontal in modern man. Now in the 20s, McCollum and their group found the hinge axis and realized that was more clinically significant than the ear hole, so they moved the two posterior points downward and forward to the axis, but left the third point of reference the same at orbitale, creating the axis orbital plane of reference. So when we have a patient sit erect and look straight ahead, the face bow will be often canted upward here in the front. The vertical post is also canted. But every time we go to the articulator to mount, the vertical post is always related vertically. So this would accentuate the plane of occlusion as we go to the articulator. So we developed a little adjustable nasion relator and a level gauge, and we can turn the screw here in the center of the housing so we can separate these housings, leveling the front of the face bow down to what I call an arbitrary axis horizontal plane of reference. Although the face bow is level from a profile view, once we look in the frontal plane, we can see this patient has one ear that's slightly higher than the other. So we can have the patient move the face bow in the soft tissue of the ears, leveling the face bow as they look at the level gauge. This will now free up our hands to go ahead and attach the clamps to the bite fork and then we can take that bite fork to the articulator to mount the maxillary cast. So if we could look through the patient's cheek here and see the steepness of her plane of occlusion, we get the same result on the articulator. And looking at the frontal plane, we can see a cant to the occlusal plane running downhill from left to right. We'd get that same look on the articulator when we mount the cast. So now we can do an evaluation of whether we want to do some gingival recontouring on this side for symmetry and balance, whether we want to prep more on this side or add back to this side to level the plane of occlusion for both function and aesthetics. We also developed the COIS Dento Facial Analyzer System, which is a simplified face bow. It looks a lot like a Fox plane where we've added a little vertical rod. It has an index tray and an adjustable platform. Again, we're looking at the occlusal plane to someone's eyes, but when I talk about the dental midline and ask whether you want it straight or canted, everyone agrees that they want it straight. Straight to what? The eyes or the horizon? Well, actually to facial midline. See, facial midline will actually dictate your dental midline. Then your dental midline will dictate your occlusal plane. It'll be perpendicular to that. It's just what laboratory technicians do. Well, we looked at the research of ear bows, and it showed that 75% are within 5 millimeters of the axis, which is an acceptable range for mounting casts. They show if it's off 5 millimeters from the axis, creates a minimum error at the tooth level. So Dr. Coy said, do we really have to relate the axis to the ear hole, or can we relate the axis directly to the teeth? So he did a study measuring the distance of the hinge axis to the central incisor and found it averaged approximately 100.21 millimeters. And if we go 5 millimeters below to 5 millimeters above, it encompasses about 75 to 80% of the patient base. So statistically, it's about the same as an ear bow. So we're going to standardize the system to an axis incisal distance of 100 millimeters. Knowing this, all we got to do is pick up one of these 2 points in a face bow. I'll engineer it that the second point is 100 millimeters for the first point when we get to the articulator. Other related research would be Bonwell's equilateral triangle. Monson's spherical theory of 4 inches happens to be approximately 100 millimeters, and of course Weinberg studies. Well, Bonwell's equilateral triangle states that from condyle to condyle is 110 millimeters, and from condyle to incisal edge is 110 millimeters, which would create an equilateral triangle. But from the center of the axis forward is about 98 millimeters, which was within 5 millimeters of Dr. Coyce's 100 millimeter average. Weinberg was showing from the center of the axis out 100 millimeters and then down 32, but the axis incisal distance was again within 5 millimeters of Dr. Coyce's 100 millimeter average. So we have a vertical rod that we slide into the slot, and we slide in the slot because some people have shorter noses and some people have longer noses. And the closer we are to what we're trying to reference to will make this system less subjective. You can also see that we have little holes in the plate here. We'll accept the pins on the bottom of the Coyce index tray. So we seat the Coyce index tray all the way down onto the dental facial analyzer. We can then add our bite tabs, the red impression compound on a self-adhesive strip. Add 2 back in the molar area, and I also like to add 2 more over the bicuspid area. We can then temper that compound in hot tap water, and once it's softened, we can then mold that compound into a cone shape to build more height in the compound, especially if we have a steep plane of occlusion situation. If we had a reverse plane of occlusion situation, I may squeeze the compound in the front up a little bit higher. Well, step 1 is to set the wall that's on the Coyce index tray to the central incisor, picking up 1 point of that axis incisal distance for function. Step 2 is get the vertical rod to facial midline. Well, what is facial midline? I like to split the eyes and use the philtrum of the lip, but you have to decide what facial midline is. We can also see that the lateral wings going down the side of the face are approximately level, and then we come straight up to whatever tooth is lowest in the arch, hits the tray, and stop. We can do this in the supine position so we can really focus on the vertical rod, which is the critical aspect of this system. If you get a 1/2 degree cant in the vertical rod, you're more than likely to get a 1/2 degree cant in your dental midline and your final prostheses. So now we capture the cants and tilts of the occlusal plane in the bite registration material on a horizontally aligned index tray. We can now come to the articulator where we set the incisal pin to 0. We have an adjustable platform that will adjust to the 0 line for mounting, and then we index the adjustable platform to the lower magnetic mounting plate. We can then add the index tray to the holes onto the platform, which will now align the wall on the index tray 100 millimeters from the center of the axis of the articulator. Notice how the platform also creates a built-in bite fork support system that will support the cast during the mounting procedures. So there's no longer a need for mounting wedges, jack screws, or even plaster under your bite fork for mounting. So now we can add a mounting plate and plaster and make a connection of the upper cast to the upper frame. And I believe the upper cast should be more of an aesthetic relationship. It does have to be related to an axis of rotation because we use that upper cast to mount the lower cast with the centric relation record, which is your functional mounting. It'll dictate how the lower teeth approach the upper teeth as long as you're within a statistical average of the axis of rotation. Dr. Kois also uses his Dento Facial Analyzer for dentures. What he'll do is set up the incisal edge where he wants it vertically in the face as well as anterior-posteriorly for lip support. Then he'll take the back of his mouth mirror and make a couple orientation dimples in the occlusal surface of the bite rim. Then he'll take a PVS material and put it on the Kois index tray and take a face bow registration of the bite rim. Here we can see the little orientation dimples in the bite registration material so that the bite rim will reorientate correctly onto the Kois index tray when we come to the platform to mount the cast. Then we can use the platform as a guide for setting our occlusal plane and making sure that the aesthetic relationship of the occlusal plane is correct, as well as tooth widths. Well, we also have a Broderick occlusal plane analyzer that we can use to evaluate the occlusal plane or the curve of spee. It's based on Monson's spherical theory of 4 inches, so we'll set the compass at 4 inches, and we come to a canine point on the lower cast and scribe an arc here on the flag above the articulator. We'll then come to a molar point and scribe another line on the flag. If you don't have one of those 2 points, you can also come back to an axis point here and scribe a third line. Notice how all 3 lines intersect basically at the same point. We can now readjust the compass to that point and then sweep the compass across the occlusal surfaces of the teeth to evaluate the plane of occlusion or the curve of spee. Centric relation. I'm not sure if I really like this term. I like the term stable condylar position. It just makes orthopedic sense to seat the condyle in the fossa. And we do this by some type of anterior deprogrammer. Here's shown as the Panadent bite tray with a compound jig. It's this anterior deprogrammer here that creates a fulcrum point, allowing the mandible to rotate around that fulcrum point upward and forward into the fossa without interferences of the posterior teeth. We do this by taking a centric relation record, by adding a bite registration material to the upper side of our bite tray to get an index of the upper teeth of the patient. Then we'll add a lower compound jig, although you can cut the anterior section of the tray away here and use it with a leaf gauge or with a Lucia jig. Here we're showing a compound jig. Then we go to the mouth and actually push on the lower jaw back to get the most retruded of the position of the mandible. What we're trying to do is push the jaw back from a CO or MIP position back to CR or the apex of Posselt's rhombus. We then check to make sure we have no posterior contacts of the posterior teeth, and then we can add a bite registration material to the lower posterior half of the bite tray. Then we can see that the teeth fit very accurately in the bite registration material. Then we can test our study cast to see if they fit the record as well. And if the models don't fit, then maybe the models are inaccurate. We then take the centric relation record and index it to the upper cast, and then index the lower cast into the centric relation record. And we now have the articulator upside down in our mandibular mounting stand. And with the mandibular mounting stand, we can actually adjust the front end of the articulator down so we can level the cast here so that the plaster will stay in place. We can now add plaster to the model and the mounting plate, swinging the lower frame around, making a connection of the lower cast to the lower mounting plate. Centric relation versus stable condylar position. We developed also the API or CPI system to help track condylar stabilization during splint therapy. We can also use it to determine slide versus fulcrum and also to verify interocclusal records. The CPI system is a dedicated articulator with built-in graph supports, where the API system are graph supports that can be put in place of the motion analogs on the articulator. And then we add a paper graph on here that has a grid, and now we have these models that are mounted to the original CR position. And so I would expect the mark on here would be right at or near the crosshair of this graph paper, so we'll mark that with a piece of marking ribbon. Then we'll put the patient on splint therapy for a period of a couple days to a week and have him back and take a new centric relation record. And we'll stick the second relation record into the originally mounted cast. So what we wanted to see is where's the condyle going during splint therapy. So we'll mark that with a different color. And we can see on the patient's right side that the condyle has moved up about 1 millimeter and forward about 0.5 millimeter. On the patient's left side, it's gone up a little over 1 millimeter and gone forward about 0.75 millimeter. And we can do this weekly until we achieve the points at the same position, verifying a stable condylar position. Well, is it a slide or is it a fulcrum? When you take a central relation record, many times you'll have a posterior interference and you'll end up with an anterior open bite. And if you have the patient squeeze their teeth together, it'll appear that the lower jaw slides forward into occlusion. Well, we can actually superimpose the patient's pathway right on the side of the graph paper, and then we can take our models that we've now remounted to the stable condylar position. So we have that record of the stable condylar position in here, and when we mark the graph, I again expect it to be back at the crosshair or centric relation of the articulator. Then we'll put in an MIP or CO record so we can see where does the condyle go when the patient bites their teeth together. So here on the patient's left side, we can see the condyle is being fulcrumed away from the eminence about 1 millimeter. On the patient's right side, we can see actually the condyle is down the eminence, and that's a pure slide. And here's a case that's actually part slide, part fulcrum. The part vertically forward from the vertical line forward is the amount of slide. The distance from the pathway straight down to the dot is the amount of fulcrum. Well, protrusive pathway deals with opening or incising movement. The condyle not only has the ability to rotate within the fossa, but it has the ability to translate, and it's this downward forward movement of the condyle as a discluding factor. And they show that if you have a flatter eminential angle versus a steeper eminential angle, it will affect the approach of the opposing teeth. And that's true, but they left something out of the equation. In other words, we want to know what the discluding factor of the condyle is, because you can't change that, but you need to override any negative effect this condylar movement has on your posterior teeth with the other discluding factor you can change, the anterior teeth. So when we look at a steep plane of occlusion situation, an opening movement would be a lot like a vertex where the axis is in line with the occlusal plane, and I expect to see excellent disclusion in opening movement. Problem is with the protrusive pathway, the plane of occlusion is very close to that, so you see little or no separation of the teeth in a protrusive movement. If we take the extreme opposite of that, of a reverse plane of occlusion, I expect to see excellent disclusion in a protrusive movement, but yet I expect to see very poor disclusion during an opening movement. So, what we'd like to do is actually create a fairly level plane of occlusion or a slight plane of occlusion for aesthetics, so we get disclusion during opening movement, which sets up the mesial inclines of the upper teeth, as well as disclusion in a protrusive movement, which sets up the distal inclines of the upper teeth. And we can record this protrusive pathway by using our AxIPath recorder, which traces the protrusive pathway as the patient slides forward and slides back. We can then superimpose the protractor onto the patient's pathway here, and then read the axis orbital reference line out to the patient's condylar inclination on the right side. We can do the same thing on the patient's left side, superimposing this pathway onto the patient's pathway, reading the reference line out, getting the inclination of the patient's left side condylar inclination. We can also get this information by using a protrusive record, where we use the bite tray again, and the procedures are the same as the centric record for the upper side, getting an index of the upper teeth. Then we add a lower compound jig. We go to the patient's mouth, and we actually have them retrude and make a centric index first. Then we have them open, come forward until they're edge to edge, and bite up into an edge to edge position. We can then see that we've gone forward between 5 to 7 millimeters in measuring that protrusive pathway. And we also know that the record that has 2 indexes in it is our protrusive record, while the one that only has 1 index is our centric record. We can then add the bite registration material to the lower posterior half of the bite tray, go back in the patient's mouth, guiding them back to that edge-to-edge protrusive movement, and then holding the tray in place while the material sets. We can then take that tray to the articulator that's moved the lower frame and the cast downward forward to that edge-to-edge position, and we can now loosen the screw, allowing the guide system of the articulator to fall down to where that axis element is moved downward and forward in the fossa, setting the patient's protrusive pathway. Bennet pathway deals with lateral or chewing movement. Bennet described a lateral shift of the working side condyle. And as we look straight down on top of someone's head and look at opening movement, the mandible translates forward. Then we'll move laterally to a chewing side, and the working side condyle moves upward, outward, and backward as the non-working side shifts in. Now we're coming from a lateral position back into full occlusion. As the working side shifts in, this is what Bennet described. But the non-working side is moving upward, outward, and backward in a curvilinear pathway, so I like to call this Bennet movement. And if you have a little bit of Bennet movement or inward movement of the condyle versus a lot of Bennet movement, will affect the approach of the opposing teeth. And it almost looks like you have to grind these teeth down no matter what Bennet movement you have. That's because they left something out of the equation, the canine guidance. In other words, if this was your restoration back here and this is a big interference, I'm sure you don't like that and you may want to adjust that. But I'm saying let's look at this canine, which has a lot of wear on it, and if we added back a millimeter or so to this canine, would we not clear that interference? That's why diagnosing and mounting casts on our articulator is so important. And we can actually measure this Bennet movement with our AxioPath recorder, where we have the patient move laterally 3 millimeters, and then we push at the angle of the mandible to simulate a hard chew. And as we push at the angle of the mandible, the condyle is moved inward, downward, forward, and as the condyle is moved inward, the recording arm is attached to the mandible, so it also moves inward. That'll push the stylus out, giving the measurement or amount of Bennet movement taking place at the joint. We can also get this information using our analog selectors with lateral check bites to measure the Bennet movement. History of recording devices is the pantograph. The definition of a pantograph is two rigid bodies that move relative to each other. And the Stewart pantograph was an ingenious system, but it had telescoping styli, so it actually wasn't two rigid bodies that moved relative to each other. But it did have clutches over the teeth with a central bearing screw, and they'd paint the vertical and horizontal graphs here with a chalk-like material. And as the patient moved around in border movements, these styluses would be scribing those movements on the vertical and horizontal plate. Then they'd mount the whole recorder, along with the models, into the articulator, so they could try to move the articulator, simulating the same movement scribed on the vertical and horizontal plates until something bound up in the guide system. Then they'd mark that with marking ribbon and basically custom grind an analog of motion specific for that patient. Well, Dentures came out with a mini recorder where they move the stylus forward from the hinge axis. And when you do that, you lose fidelity. In other words, was it more easier to grind in this complex curvilinear movement here, or was it much easier just to set a quote-unquote Bennet angle? So you lose fidelity by moving away from the source you're trying to record from. Other misinterpretations would be the Fisher angle, the backlash, the Gothic arch, and immediate side shift. So the backlash is actually an artifact from recording outside the center rotation of the condyle. The condyle isn't actually going back and up into the brain. The Fisher angle here might be actually due to the shape of the condyle or maybe an inaccuracy in locating the hinge axis. The Gothic arch was again the stylus trying to keep up with this plate that's moving away from it, and it'd create this sweeping motion or so-called Gothic arch. The stereograph is actually two rigid bodies that move relative to each other, so it is a true pantograph. It had a central bearing screw in the center here, and it had these steel studs here where they put soft material in here and had the patient move their jaws around in border movement and mold in basically Posselt's envelope of motion. And again, you can see that we didn't see the so-called Gothic arch. It looks more like a Greek arch. Then they take these plates and mount it into the articulator and then put some acrylic up in the guide system here, moving this around, molding a custom analog of motion specific for that patient. Well, it all deals with two-plane versus three-plane pantography. In two-plane pantography, the condyle moves inward, downward, forward in a curvilinear movement, and the vertical and horizontal stylus record that movement onto the plates. The problem arises when you go to the articulator that this point could stay at point A while this stylus shifted straight across from A to B, inducing what they called immediate side shift in the articulator. And then this stylus would race down to point C to catch up with this stylus, tracing in the patient's protrusive pathway. Well, is it immediate side shift fact or artifact? Well, as you move your jaw laterally, the condyle is actually moving down, which is moving the plate down away from the stylus. And you can see from the edge of the plate to the stylus here to the edge of the plate here to the stylus is a longer distance. So as this plate moves down, the stylus stays in the same orientation, and it creates this sweeping motion across the plate or inducing in an artifact of immediate side shift on the recording plate. Well, it all deals with 6 degrees of freedom, that there's translations as well as rotations in all three planes of space. As the condyle moves inward, downward, and forward in a curvilinear movement, the vertical stylus and horizontal stylus are recording the same movement on the vertical and horizontal plates. But now we have a frontal plane here. So when we go to the articulator, this point can't stay at point A while this one shifts across. Otherwise, we'd see it shifting straight across here. So the frontal plane really gives the timing between the vertical and horizontal plates. So when we go to the articulator, we reproduce that curvilinear movement that we got from the patient. The axiopanographic research data showed that 100% of the 220 patients' right and left border movements, 440 movements, showed a downward forward position of the contralateral condyle from CR. In other words, we did not see immediate side shift. He published his results in the Journal of Prosthetic Dentistry in 1969, part 1 being the recording apparatus, where he did not know what the intercondylar distance was, but he standardized the drills at 220 millimeters apart. And these were actually air-driven drills that went into solid plastic blocks. So as the patient would move their jaw laterally, the drill would be grinding in the patient's movements into these solid resin blocks. So let's take a look at the research film at this time.
The left lateral recording is verified by repeating the border movement to the left. And then to the right. These repeat movements are done to make sure that the mandible was tracing a true border movement. The protrusive recording is verified by repeating the movement. The mandible is again placed in centric relation in preparation for recording the movements of the hinge axis. With the mandible in centric relation, the two axis drills are made to penetrate their associated recording blocks a predetermined depth, as indicated by calibrations on the turbine carriage. The turbine carriages are locked when the drill tips are precisely at the standardized distance of 220 millimeters apart. The left lateral movement is shown being recorded on the right side of the patient. While the right side drill is recording the left lateral movement as shown here, the left side drill, which cannot be seen, is recording the same movement in a reverse direction. The mandible is returned to centric relation with the drills inactive. The right lateral movement is now recorded and appears on the working side as a backlash. The mandible is returned to centric relation with the drills inactive. The axis record blocks are switched from right to left so that the blank sides may be used for recording the protrusive movement. The mandible is retruded to centric relation and the axis recording drills are made to penetrate the new sides of the record blocks. They are locked at the same depth as they were for the recording of the lateral jaw movements. The same 2 points 220 millimeters apart on the hinge axis which were previously traced in the lateral jaw movements are traced in the protrusive movement. The mandible is returned to centric relation with the recording drills inactivated. The anterior reference pointer is adjusted and secured to the orbital spot on the right side of the nose. Note that the orbital spot has been marked temporarily with dark ink for photographic clarity. The recording equipment is removed from the patient by loosening the attachment clamps. Here in these resin blocks are recorded in 3 dimensions the right and left lateral and protrusive movements of this patient's mandible. Part 2 of this motion picture will show how the information stored in these 3 blocks is reconverted by a secondary pantograph to locations near the condyles. This procedure produces a pair of motion analogs which will serve to guide and control the movements of an articulator for simulating this patient's characteristic jaw movements.
Now he could view these solid resin blocks in 3 planes of space. Here's the vertical plane where we can see the patient's protrusive pathway. Then we can look in a horizontal plane here and see from point centric the Bennet movement coming inward and forward. And then of course in the frontal plane where we see the Bennet movement coming inward and downward. Now we can see the variances in the protrusive pathway, as some had very flat protrusive pathways and some had much steeper protrusive pathways. There's also a difference in the amount of Bennet movement, as the condyle moved in a little bit on some patients, where it moved in quite a bit on other patients. So part 2 of the research was the transfer apparatus, where he standardized the intercondylar distance at 110 millimeters, half the distance of the recording drills. He'd have these resin blocks on the upper frame here, and he'd have pins simulating the drills from the recorder. So now these pins would guide this upper frame as 2 vertical mills would basically mill out a custom analog of motion specific for that patient. So let's take a look at the secondary pantograph research clip at this time.
The pointer is indicating that the patient's recording blocks have now been reversed to expose the lateral border recordings to the guide pins. The analogs are repositioned over the vertical mills in centric relation, and the guide pins are inserted into the lateral border recordings. The mills are activated and the border movements are pantographed. Here we see the right recording with an analog being generated on the left. Note the backlash effect in the recording was caused by the pivotal action of the working condyle. Observe that the Bennet and orbiting paths are magnifications of the movements at the condyle level. A closer view of the recording shows the backlash effect, the lateral and medial Bennet shift, and the Bennet and orbiting paths. Starting in centric, we see the lateral and medial Bennet shift of the working condyle, followed by the curvilinear Bennet and orbiting movements. A closer view of the guide pin shows the lateral Bennet shift and backlash, the medial Bennet shift, and the Bennet and orbiting paths. This view shows the anterior recording of the lateral border movements. Note the twisting motion of the frame as it rotates and translates in the 3 planes of space. After the border movements have been generated in the analogs, the guide pins are retracted and the analogs examined at close range. In the right analog, we see outlined the border movements including the Bennet, orbiting, and protrusive paths. Here we see the same movements on the left. This view shows that the condylar elements of the articulator and centric indicating key are spaced exactly like their counterparts on the reconverter. The analogs are removed and attached directly to the maxillary frame of the articulator for replay. Observe the right condylar element as it moves from centric to protrusion and back to centric. Outward and inward Bennet shift, inward on the Bennet, and orbiting paths. In the right working path, the balancing Bennet and orbiting paths, and back to centric. The centric pin is depressed to position the condylar elements in centric relation.
So now he could put these custom analogs of motion onto the articulator to duplicate the patient's actual jaw movements. The Gibbs Replicator was developed by Dr. Charles Gibbs and Dr. Harry Lundeen, and it actually had para-occlusal clutches, so patients could actually chew different consistencies of food. And the bows had 6 transducers on it, which actually are the 6 elements of freedom. Those 6 transducers would send signals to a 6-channel tape recorder that would then send those signals to a digital reconverter that would break them up into milliseconds, and then send those signals up to 6 servo motors that have the ability to reverse direction in an instant. So as the patient was chewing different consistencies of food here, their models were actually chewing at the same time over here. They were looking at how people chewed. But then they also looked at the condylar movements of these chewing patterns as well. My father went down with Dr. Gibbs and Dr. Lundeen, and what he did is measured a patient with his recorder and developed a custom analog of motion and mounted the cast in an articulator. Then they married the 2 systems together by mounting the articulator into the Gibbs Replicator, so that the Gibbs Replicator would then move the lower cast around so they could see if everything tracked the guide system the same as what my father recorded, which it did. So here we have 2 different researchers with 2 different instruments supporting each other's research. It also met scientific method where it was standardized. The primary investigator was able to repeat his results, Other investigators were able to repeat the primary results, and the data was in a form that could be analyzed. What they did is took all these movements and put them into a computer to come up with statistical averages of actual patients' jaw movements, which led to the development of 5 different size motion analogs of motion, ranging from 0.5 to 2.5 in half-millimeter increments. And the distribution chart shows that 15% of the patients had a half a millimeter Bennet, 52% had 1 millimeter Bennet, 21% at 1.5, 8% at 2, and 2% at 2.5. We recommend a 1.5 motion analog of motion if you're going to use a statistical average, because that'll cover approximately 85 to 90% of the patient base. So use a statistical average, use a larger Bennet movement. The major differences of condylar movements in the functional range was the steepness of the protrusive pathway and the curvature of the balancing side Bennet pathway. So if we look at a schematic of the motion analogs, here we have the sagittal plane or profile view, and we see the patient's protrusive pathway, which averaged a 3/4 inch radius. And we can rotate the analogs to set different patients' protrusive pathway angulations. The Bennet pathway again was varied a little bit by half a millimeter, creating these 5 different analogs of motion of the Bennet movement within the functional range of 3 millimeters. So here we see the balancing side Bennet pathway, which is a curved pathway like this dotted line, which has led to 3 main types of articulator guide systems. Pathway A is a straight line undercompensated Bennet guide path, where it goes from point centric out to point Bennet. And the patient can actually chew beyond the limitations of the articulator, which means from the solid line to the dotted line is a potential posterior interference. So they came out with the immediate side shift articulator, went from point centric out to side shift and then out to point Bennet, and eliminated all possibilities of interferences, as now the patient chews within the limitations of the articulator. But if you have 2 millimeters of side shift, it's only 3 millimeters from the central fossa to the cusp tip, which means 2/3 of your tooth would be as flat as this floor. So this little triangular area in here would be anatomy. So we want to copy the patient's pathway as closely as possible, like pathway C, so we can reduce or eliminate the possibility of interferences while still maximizing anatomy for chewing efficiency, stability, and longevity. So here we're showing the Whitmock's undercompensated straight line articulator going from point centric out to point Bennet, and the patient would chew a little beyond that in a curved pathway. And then here's the immediate side shift articulator. We'd go from point centric, shift straight over to point Bennet, side shift, and then go out to point Bennet, and then back. Very robotic system, very difficult to work with. Versus the curvilinear analog system of the Panadent. As you move the jaw laterally, the working side shifts out, and the non-working side moves inward, downward, and forward on a curvilinear movement, more duplicating lifelike chewing motions. So now we can manipulate the articulator by just grabbing the side of the frame, and we disclude like the patient does by simply opening the mouth. Then we'll push the articulator into a protrusive position so we can evaluate if there's any interferences in different lateral movements. So some basic fundamental functional analysis records would be a face bow registration, so we can get a relationship to the axis of rotation, as well as the plane of occlusion. Interocclusal records will give us a centric relation position, as well as the protrusive pathway excluding factor, and then mounting casts on a curved path guide articulator for more accurate jaw simulation. Well, introduction to golden proportion. There's a phi ratio of 1 to 1.618. And we do have what's called a golden ruler that maintains this 1 to 1.618 relationship. And we can use this to evaluate the face or do a facial analysis using golden proportion. And there's many proportions within the face. But you may remember the true bite mask that actually measures zygomatic width and facial length to help you choose the width and length of denture teeth for a patient. The same concept applies here, where there's lateral proportions to the face, where we're showing here the lateral canthus of the eyes is approximately 60% wider than the width of the mouth. The width of the mouth is then 60% wider than the width of the nose. Then the width of the nose would be 60% wider than the width of 2 central incisors. And they show the width of 2 would be then 60% wider than the height of 1, which would end up being about an 80% single central width to height ratio. They also show that a width of the central is 60% wider than the apparent width of the lateral. Not the actual width, the apparent width, because the lateral is slightly rotated. Then they also say that the width of the lateral is 60% wider than the width of the canine. But when they show the picture, it kind of shows a funky looking canine. Well, we did develop golden proportion waxing guides that can be added to the COIS platform to help evaluate tooth widths, the width of the central to the apparent width of the lateral to the cusp tip of the canine. And if you don't like golden proportion, I recommend visiting Dental GPS, where Dr. Elaine Mathod has developed a computer software program where you can import the patient's face and actually set up different proportions of the teeth and evaluate that to come up with a patient-specific proportion tooth guide. You can then print these out on paper and then set the model on the paper or tape this to the COIS platform to evaluate tooth widths. There's also vertical portions to the face. There's facial thirds. There's the upper third, there's the middle third, and the lower third. And as the middle third and the lower third overlap each other, they create proportions. So we do have a vertical rod from the COIS bow that has little slidable O-rings so we can annotate these different facial landmarks. Then we can use the golden ruler to evaluate from the inner canthus of the eye to the ala of the nose to evaluate incisal edge position. And here we're showing that the incisal edge is short about 2 or 3 millimeters. And if we want to add back that length for both functional concerns, we may also want to add it back for aesthetic concerns, being in golden proportion. So we can actually adjust the COIS platform down 2 or 3 millimeters, and now the teeth are suspended by the incisal pin, giving a guide for the technician to wax in tooth lengths. And then, of course, with the waxing guides, you can evaluate tooth widths at the same time. You can also evaluate from under the nose the incisal edge to evaluate the chin for vertical dimensions. You may want to change that to where you may take a shorter face or a longer face and try to make it more ideal. We also have condyle positioners, which are used for making repositioning splints or simulating model surgery. They go in place of the motion analogs, and they have little screws on the top and in the back here. And one full rotation of the screw is 1 millimeter. There's actually a little line on the screw in the housing here so you can measure the rotation of the screw. As we screw the top screw down, it would be like impacting the maxilla. Screwing the back screw forward would be like an advancement of the mandible. The combination of the two would be like an auto rotation of the mandible. We also put lines here on the shaft so we can do lateral shifts of the mandible for simulating model surgery as well. We also have an articulator test column, which has a split cast form on the middle of the column. And we can pour this up in a good dye stone so we can check the articulator from time to time to see if it's still accurate with the laboratory. We also have an adjustable incisal guide table where you can set up a different incisal angle as well as canine angles or a guide system so that we can reproduce these different incisal or canine guidance in our restorations. So now we can evaluate the occlusion of this patient, the state of being closed. Do we have equal simultaneous contacts when the joint's in the fossa? We can also check the active closure, going from a protrusive position back into full occlusion, or left lateral movement back into full occlusion, or right lateral movement back into full occlusion with no interferences of the teeth. My father also talked about graduated buccal cusp guidance. What he said was during age 6 to 12, during the most formative years of our children's lives, they don't even have canines. So what is guiding our children from age 6 to 12? The 6-year molar. And many times that distal buccal cusp falls down out of occlusion a little bit, which may be a surrogate canine. So when he had his doctors wax the case, he would wax it without the canines in and have them wax from the 6-year molar forward. So here we can see how the restoration fits on the articulator, and then we can see that it fits accurately in the mouth. Then we can see how that 6-year molar functions on the articulator with no canine guidance, getting disclusion of the non-working side. We can see how that works also in the mouth. Then when we get to canine guidance, we get excellent disclusion of all the teeth and no interferences back into occlusion. In other words, if this patient was to wear or break this canine, the first bicuspid will start picking up guidance with no interferences of the teeth. And if that was ever to wear or break, the second bicuspid picks up. And if that was ever to wear or break, then the first molar would pick up. In other words, this patient will probably never have interferences the rest of their life. It's a great little exercise. I recommend you try it. And then we can see how this also works in the patient's mouth. And you can see how accurately the articulator simulates the same movements of the patient. Well, the steepness and tilt of the occlusal plane relate to an average axis of rotation, along with smile, teeth, and gingival symmetry and balance, along with height of lip commissures, tooth and facial proportions can all be diagnosed comprehensively to achieve a superior treatment plan for optimum aesthetics. So if you have candidate occlusal planes, dental midlines that are off, and unsymmetrical gingival tissues, you can hopefully get that all straightened out the first time. Now, the Panadent Articulator with the curved path analogs of motion can be programmed either average values with check bites or axi-path recordings to reproduce the patient's three-dimensional mandibular border movements for optimum function. So here we see a lot of pathology and a lot of dentistry, but there's no teeth that look like teeth. We can restore those teeth back to the form so we can restore the function. Here again, pathology, disease, restoring the form of the teeth so we can restore the function. Is it reconstruction or rehabilitation? Many times I think we do reconstruct pathology in the teeth, maybe to a lesser degree. Rehabilitation is not a good word either, because nobody wants to go through rehab. I think rejuvenation is one of the most powerful words you can use, because it's not only a renewal of body, but it's also a renewal of spirit. So now we can take a mouth that has a lot of pathology and disease, and here's a couple of teeth that look halfway decent, and restore the individual forms of the teeth with the form of the occluded dentition in harmony with the form of the joint to restore physiology. Again, pathology and disease, restoration back into health. There's no straight lines in nature, just big, biological, and beautiful. So what is beauty? Well, Webster describes it as the quality or aggregate of qualities in a person or thing that gives pleasure to the senses or pleasurably exalts the mind or spirit. And here we can see that we have a restoration of vertical dimension, release of centric relation, and look at the renewal of body and renewal of spirit as the eyes brighten up and there's a new revigoration within this patient. Qualities of beauty is the visual perception of any object, including the face, is a function of four qualities: color, texture, size, and shape. And of course, they put form down here with shape. And I'll tell you that shape, more than shade, will make your teeth believable. So if we have an older patient, do we want to age their teeth? No, because if we change the form, we change the function. You can maybe age it with color or check lines, but you don't want to change the anatomy because you'll change the physiology. Here we see wear just starting, and we can actually mount this case up and maybe diagnose why this wear is starting and equilibrate the mouth so that the joints are in harmony with the teeth, and then add back this tooth structure for optimum aesthetics as well as for function. So some treatment goals for both function and aesthetics would be to eliminate interferences, to maximize anatomy for chewing efficiency, stability, and longevity, to create a beautiful smile, and to enhance facial aesthetics. So the rationale for articulators would be to diagnose whether we have interferences when the joint's in the socket, develop a treatment plan that's in harmony with the biologic system, to communicate with the laboratory for both function and aesthetics. You also need one for teaching or for didactics, and I think most importantly for baseline records, knowing how the patient came to you, what you did to them, and how they are now. We're compatible with all specialty and disciplines, including orthodontics, orthodontic surgery, prosthodontics, implantology, periodontics, restorative dentistry, and I think we develop some tools and techniques to accomplish aesthetic or cosmetic goals at the same time. Our benefits is that we're user-friendly, we have simplicity in design, we create time-saving procedures so you can communicate with the laboratory for both function and aesthetics, we give great education support, and being more predictable in your treatment is creating a cost-effectiveness. Our mission is we're dedicated to providing quality, innovative products and exceptional customer service to the dental profession since 1974. If you'd like more information, please contact Panadent at the following address. And I want to thank you for your attention and have a great day.